Hi, and welcome back to the Pro PA podcast, where future pros in medicine are made. I'm Angie Urbina, your host for this dermatology series, and I'm thrilled to bring you another high yield clinical topic. Today we'll be diving into erythema multiforme, an immune mediated condition often seen in primary care and emergency settings. Erythema multiforme can sometimes be confused with other serious skin conditions. But don't worry, we'll break it down so you can approach it with confidence. Let's jump right in. First, let's start with the basics. Erythema multiforme, or EM, is an acute immune-mediated condition. The hallmark is the appearance of target-like lesions on the skin. These lesions may involve the mucosa, which helps differentiate EM major from EM minor. Most cases are triggered by infections with herpes simplex virus, HSV, being the most common culprit. And less commonly, EM can be triggered by medications, autoimmune diseases, or malignancies. You can think of EM as the immune system overreacting to an underlying trigger, whether that's a virus, a drug, or another irritant. Now, let's talk about how EM presents. The hallmark of EM are target lesions with three distinct zones: a dusky center, a pale ring of edema, and an erythematous halo. These lesions are typically less than 3 centimeters in diameter. The rash is often symmetrical and starts on the extremities, especially the hands and feet, before spreading inward. EM minor is what it is called when a patient presents without or only mild mucosal involvement and without systemic symptoms. But in EM major, which is basically a more severe course, mucosal involvement is a key feature. This could include the oral mucosa, ocular, or genital mucosa, and patients may also have systemic symptoms like fever or joint pain. One more thing to note about its presentation is that EM lesions can appear at sites of trauma or irritation, which is known as the Keebner phenomenon. As far as the diagnosis, in most cases, EM will be diagnosed clinically. You want to make sure to take a thorough history and physical exam. Ask about recent infections, medications, or any systemic symptoms. If the diagnosis is uncertain or you are concerned about something like Stevens-Johnson syndrome, a skin biopsy can be performed. Now, on to the management. For most patients, EM is self-limited, resolving within 2 weeks. The focus is on symptomatic relief. Topical corticosteroids and oral antihistamines can help alleviate itching and discomfort. For patients with oral involvement, though, topical corticosteroid gel and mouthwashes that contain lidocaine can offer relief for their oral pain and lesions. In addition, in cases where EM is linked to HSV infection and is occurring multiple times per year, continuous antiviral therapy like acyclovir may be used to prevent the patient's recurrences. A very important complication that you want to be on the lookout for is ocular involvement. Ocular involvement could lead to long-term damage if not treated properly, so these patients will need referral to ophthalmology. Here are some quick clinical pearls to keep in mind. Number 1. Target lesions are the hallmark feature of EM. You don't want to miss them. And number 2. Always check mucosal sites for involvement to differentiate between EM minor and EM major. Remember that this will play a big role in your management of the patient. All right, let's test our knowledge with some clinical questions. Number 1. A 25-year-old man presents with a rash to his palms and soles that started this morning. He reports some itching but otherwise denies any other symptoms. He also reports having cold sores on his upper lip about a week ago. Examination reveals erythematous, iris-shaped papules to his palms and soles. What is the most likely trigger for his condition? Is it A. Mycoplasma pneumoniae, B. Herpes simplex virus, C. Sulfa drugs, or D. COVID-19 vaccination? I'll give you a couple of seconds. If you chose B, Herpes simplex virus, you are correct. Although sulfa drugs and Mycoplasma pneumoniae are common triggers of EM, HSV is the most common cause and goes along with this patient's history of cold sores. On that note, let's just say this patient just so happens to end up having multiple HSV associated recurrences throughout the year. Then he would be a great candidate for continuous antiviral therapy. Question 2. A 28-year-old woman presents with a mildly itchy rash to her hands and feet that began last night. She denies any mucosal involvement or any other symptoms. She recently had an upper respiratory infection but is otherwise healthy. Examination reveals erythematous target lesions that are mildly tender to palpation. Which of the following is the treatment of choice? Is it A, oral prednisone, B, topical corticosteroids and oral antihistamines, C, oral acyclovir, or D, hospital admission for IV immunoglobulin? I'll give you a couple of seconds. If you chose B, topical corticosteroids and oral antihistamines, you are correct. This patient is presenting with EM minor, which is self-limited and typically managed with symptomatic relief. This includes topical corticosteroids for the localized lesions and oral antihistamines for the itching. Great job! That wraps up our discussion on erythema multiforme. It's a fascinating condition with a wide range of presentations, but with a solid approach, you can manage it effectively. Now, don't forget to hit that subscribe button and turn on notifications so you never miss an episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you in the next episode.